So the last portion of Unit 3C, we talked about focuses on the newborn at risk. So we have focused on mom, we've focused on some of those causative factors that overlap mom and baby, and now we're going to be talking about causative factors when we're looking at the newborn complications. Some of these factors include preterm delivery, infection like neonatal sepsis, and congenital anomalies. Alright, so first of all, let's talk about weight concerns. Low birth weight is anything less than 2,500 grams or 5 pounds 8 ounces. Very low birth weight is less than 3 pounds 5 ounces or 1,500 grams. And extremely low birth weight is less than 1,000. Very recently I had the privilege of being able to take care of a very low birth weight infant, and our whole goal was getting him up to 4 pounds so that he could be safely transferred home in his car seat. Frequently, our intrauterine growth restriction, IUGR babies, correlate to having a small for gestational age infant who could also be categorized as very low birth weight infant. So first we're going to talk about the respiratory system. So the respiratory system is one of the very last fetal systems to mature. How quickly the respiratory system is activated at delivery determines the neurological sequencing of event for that infant. So it's so important to establish effective respirations directly at the time of delivery. Complications of prematurity include poor surfactant production. Remember, surfactant is that phospholipid which allows the alveoli to stay open. A premature infant also has an unstable chest wall because the bony thorax has not been yet calcified. So in these little things, a t-shirt itself might be too heavy. When you're looking at these preterm infants and they're in their isolates and you don't see them dressed in clothes, well, partially that's part of the reason, is even the pressure of clothing can sometimes be too much. They also have an immature respiratory center, so these little ones are more apt to have apnea, true neonatal apnea, where they completely forget to breathe. They have a smaller lumen in their air passages, so meaning that it's easier to collapse or occlude. And then they also have a weak or an absent gag reflex. So let's look at our diagram here on the bottom of the page. You can see when you're looking at what a preterm lung development looks like at 24 to 35 weeks, and again, little infants fall along the gradient, somewhere in the middle there. But the point being that those alveoli just have not been able to develop, and their surfactant isn't there either to help those alveoli to stay open. So we need to assess our newborns for respiratory distress. So signs of respiratory distress include nasal flaring. So observing for nasal flaring means that you have to actually look at the nares of the infant. You'll see them moving outward in an attempt to actually pull in more oxygen. They're trying to increase their surface area. Nasal flaring is seen on inspiration, and it's typically a sign of respiratory distress. This will correlate over to your pediatric rotation in 4th semester when we're talking about retractions and whatnot. Nasal flaring also has direct implications upon your young children. Retractions are going to be named according to location, and suprasternal retractions, so in above, the sternum, are going to indicate an upper airway obstruction. Tachypnea, which is anything greater than 60 breaths per minute. Grunting, those babies and those small children are using every little bit of energy that they have to breathe. And so here, sound. Apnea. What is true apnea? 15 to 20 seconds pause or longer in breathing. Typically, you're going to see a dip in their heart rate. You're also going to see a dip, obviously corresponding in their pulse oximetry as well. Abnormal breath sounds, crackles, wheezes, etc. The diagrams you have over on the left, when we're talking about the retractions, you've got intercostal, so pulling between the ribs, suprasternal, clavicular, subcostal, and substernal. If I'm taking a report from you, I typically work on pediatrics. If I'm taking a report from you on a baby that is in my emergency room, if you can't identify to me where the retractions are, that's a problem. So I would definitely put that in the back of your piggy bank as to something that is really important to me as your instructor for you to understand. Some other disorders include respiratory distress syndrome. So now you know what respiratory distress looks like. What is the etiology of it? What is the cause of it? We can have some respiratory distress syndrome. We can have transient tachypnea of the newborn. We can have meconium aspiration syndrome, and we can have centralized apnea disorders. So respiratory distress syndrome, and why does this impact the newborn or the premature baby? Well, at its very, very basic, it results from a lack of surfactant, and we know our preterm babies don't have the amount of surfactant that term babies do. So yes, we can surf them. We can give them artificial surfactant, but at that time, we can't do it just right after they got born, right? First, we have to stabilize the baby, and we have to develop some sort of air movement, we need to stabilize the airway before we can start surfing them. So how much better is it for a baby to be born with their surfactant production already at its optimal levels and ready to go? We can also have atelectasis that occurs because we don't have that surfactant. So there's kind of that stiffening of the lung tissue. Preterm babies, you can also see preterm babies who have grown up and who are in their teens. You can see scarring from a lot of these episodes where they've had stiffening of this lung tissue that led to pneumonia or something later on in life. It's very harder to it's much more difficult to initiate respirations in a preterm infant versus a term infant, and a lot of that goes back to that surfactant production and just the lack of surfactant, the lack of the number of alveoli, the lung immaturity that's there. So what are those signs? As I mentioned before, your heart rate is going to drop. Okay, if you don't have the respirations there, the cardiac is the next system to fail. So it's correspondingly different to what you have in the adult world, where the cardiac system fails, then the respiratory system tends to fail. In infants, respiratory is the driver. So we have a respiratory change, and then within moments you'll see a cardiovascular change. In neonates, we begin compressions, chest compressions, at heartbeats less than 60 beats per minute. Remember, how do you do chest compressions in an infant? It's your 2 fingers or your thumbs encircling technique, right? These babies become cyanotic. Remember that central cyanosis? I'm not worried now about the peripherals. I'm concerned about central cyanosis, so blue around the lips or in here in the chest as well. Hypoxia, hypotonic. They're unresponsive to stimuli. So think of how does that affect your APGAR scoring? Are your APGARs going to be high or low? If you have low APGAR scores, what does that tell you as a nurse about a baby that you're admitting to the NICU from labor? So we try to do a few things, right? So we try to determine risk prevention. So if we notice during prenatal care that there's any risk factors, go back to our 3A discussion. If we've noticed that there's preeclampsia, if we notice that we have an increased risk of bleeding, if we've noticed, and and that increased risk of bleeding might give us more of a preterm delivery. If we might have to induce a little bit sooner because we're preeclamptic with severe features. We're going to assess all of those things, right? And then we're going to say, okay, so mom is more at risk for having a preterm delivery. So this is what we're going to do. We're going to do an amniocentesis, and when we're doing the amniocentesis, we're going to look at that LS ratio. So the lecithin increases with lung maturity. So if you're looking at this diagram over on the right, okay, so as the further along in gestation we go, we have a higher lecithin amount. Sphygmomycin kind of stays the same, right? That concentration it peaks at like maybe a 5, 5.5, but overall it's fairly steady. So this is analyzing kind of the surfactant production, okay, when we're doing this, when we're looking at this. So a 1-to-1 ratio, when we're looking at an LS ratio, indicates fetal lung immaturity. Okay, that would put that baby, if we were at a 1-to-1, that LS ratio, that would be like slightly under that 30-week gestational mark. Okay, a 2-to-1 indicates a good chance that this baby will be just fine. And then a 3-to-1 is kind of what we're aiming for if we're having to do induction for a gestational diabetic or preeclamptic mother. We're going to try to get mom to at least that 3-to-1 ratio. Remember again that hyperinsulinemia and hyperglycemia decrease production of surfactant. Remember that from that discussion. Okay. Again, go back to your signs and symptoms of respiratory distress, and that'll give you an idea of what respiratory distress syndrome looks like. The nasal flaring, your expiratory grunt, your crackles, your retractions, that's cyanosis, tachypnea, tachycardia. We're going to do a chest x-ray on these babies as soon as we get that airway stabilized, and we're going to see a ground glass appearance. It's classic indicator of respiratory distress syndrome. We're going to see hypoaeration on that chest x-ray. You're not going to see the lungs clearly all the way down where you would expect them to be, kind of at the bases with that full inspiration of the rib cage, because they're being underexpanded. Okay, so hypoaeration, underexpansion. At this point, our first priority is oxygen administration. So before anything else, the NICU nurse is going to turn on her oxygen and attach the equipment. Okay, if the nurse doesn't do it, you know who's doing it? Respiratory therapy. Because who's called to our deliveries at Swedish American and in almost any other hospital that's high risk? You're going to have a neonatal nurse practitioner or a neonatologist. You're going to have a NICU nurse, at least one, and then a respiratory tech. We're going to give exogenous surfactant, and that once we have stabilized that airway, we're able to do that, and they usually respond fairly rapidly to that. We do not have to disconnect them at all from their airway equipment in order to give them that exogenous surfactant. Okay, we're able to give it through their vent, through their CPAP, through their BiPAP, whatever it may be. When you're looking at ventilator settings, we're going to be concerned about the PEEP. So when we're using PEEP and PIP, when we're doing our artificial ventilation, the PEEP utilizes an extra puff at the end of expiration in order to prevent alveolar collapse. So we don't want, when we don't have a ton of surfactant, we don't want these babies to have alveoli that completely collapse. So there's that little bit of puff to prevent that complete collapse. They can still close. We don't want them to stick together. We're going to monitor and we're going to titrate the oxygen use. These babies, within the first 10 minutes of delivery, okay, go back to your very Unit 1 information, okay? How many processes have to occur in that newborn's brain in order for them to breathe on their own? Okay? Now think about what is happening in the cardiovascular system. Those holes are being closed off in the heart. We have changes within, that the arteries and all of that, our pulmonary arteries. All of those changes are occurring, okay? Does a baby need to come out sitting at 100%? Absolutely not. It's because of those changes in gradient pressures that we see the holes in the heart begin to close off, right? So when we're giving oxygen to a baby, there is no need in the neonatal time period to be concerned about 100% sat. We titrate their oxygen, and we also titrate, when I'm talking about oxygen, I'm not only talking about the amount of flow, the liters per minute, but I'm also talking about the FiO2, the fraction of inspired oxygen. So you and I breathe out at room temperature 21% oxygen. When we give people oxygen via nasal cannula, we're giving them 100% O2. Well, there's quite a gradient difference there, right? Between 21 and 100. So maybe we only give them 40% oxygen instead of 100% and see how they're able to do. And that's when we start talking about high flow oxygen that you'll be seeing more of in your pediatric rotations. So there is no need to blow out 100%, because if we do that, we'll end up with one of those complications, which is called retinopathy of prematurity, or ROP, which we'll be talking about, okay? When we're talking about exogenous surfactant, as I mentioned, we can give that straight through the ET tube. They can maintain on mechanical ventilation during that time period. TTN, I finally saw a baby with true TTN over the last couple of weeks. So TTN is called transient tachypnea of the newborn. So this is generally a benign, self-limiting condition. Okay, so any infant of any gestational age can have this shortly after delivery. It's caused, remember all of that fluid that's in their lungs after delivery, or just prior to delivery, that we're hoping in the vaginal canal as it goes through that descent process and the contraction process is kind of being squeezed out, and that infant then is being suctioned shortly after the head is born with just the bulbs are in. No need to be aggressive here, people. And they're clearing all of those secretions, and it's okay to have those crackles within the first 2 hours. Remember all of that discussion? Okay, these TTN babies are having a little bit of a problem doing that whole process. That leads to ineffective gas exchange, respiratory distress, not respiratory distress syndrome, but respiratory distress and tachypnea. Because it mimics so many of our other disorders, it can be a little bit more difficult to tease out. So we monitor these babies really, really closely, and if they continue to go down the spiral, then we start flipping them over to more of that respiratory distress syndrome. If they're able to stabilize on their own, then we call it the TTN. So what are our maternal risk factors? Delivery before completion of 39 weeks of gestation, just because, once again, closer we get to that term gestation, more of that fluid is cleared out with those prostaglandins, blah, 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 all of that great stuff. Cesarean section without any kind of labor, gestational diabetes, maternal asthma. If they are male, if they've had some perinatal asphyxia, if they are premature, if they are small for gestational age, or if they are large for gestational age as well. So we do a chest x-ray on these babies perhaps, and remember, what are we going to see on our respiratory distress? We're going to see that ground glass appearance on the chest x-ray. We're going to see that hypoaeration. Are we going to see that in our TTN babies? No. Now, that doesn't mean in 2 or 3 hours that we haven't progressed to RDS, but not initially. Remember, this is a benign, self-limiting condition. So, look at your overall clinical picture. Meconium aspiration. Doesn't it sound lovely? So, meconium aspiration. Look at your diagram over here on the left. So, this baby has been either stressed at some point during the pregnancy or the delivery, or is at post-stage gestation, or some other factor has occurred that this infant has passed meconium or passed stool in the uterine sac. Okay? And then let's look at it closer in that diagram way over on the left-hand side, looking at what it is doing to those bronchioles. Okay? And so they aspirate, it's warm, it's moist, it's meconium, it's stool, there's bacteria. Not a ton of bacteria, but it's more so the fact that meconium is super, super sticky. Okay? So meconium can be very hard to expel versus, your typical sputum. So prevention is key. Don't stress your babies. Okay? Why does a baby pass meconium in utero? As I mentioned, they can be stressed. It can also be in response to hypoxia. They're gasping, they're bearing down. It's a vagal response. So management. Treatment really is dependent upon the infant status. We've come a long way in the past 10 years as to how we treat meconium a mech baby. So a mech baby, our amniotic fluid is stained. Okay, so that's a great thing to know about when you're getting a report on the mother-baby unit. Is my fluid clear or is it mech? Okay, and then how is my baby responding? If my baby is struggling, then they possibly will place an ET tube. They will possibly intubate to deep suction the trachea and the bronchi. I would have to say that this is really out of favor these days, unless the infant is particularly struggling because of the amount of trauma that can occur. Most times we're going to try to have the infant expel it on its own. They said that they would, I was listening to our neonatal nurse practitioners talk about the fact that these babies would be screaming and crying, be extremely vigorous, and they would still deep suction them. Well, if they're vigorously crying, they're transitioning well, and there's no need to go down there and do all of that potential trauma, and instead allow the newborn to expel that on their own. So if a baby does, however, have true meconium aspiration and is unable to clear that effectively, the pulmonary tissue obviously becomes inflamed as it reacts to a foreign substance. That meconium is super sticky. By this point, I would hope that all of you have tried to wipe a baby butt with meconium, and you're like taking the baby wipe and you go down and like the meconium doesn't move off of the butt. You take another wipe and like a smidge comes off, and pretty soon you're just like trying to be as careful and as gentle as you can to try to get this meconium off of that butt. It's super sticky. It obstructs that airway. Airway obstruction leads to hypoxia. If they do this before they're close to being born, you can also have a decrease in the surfactant production. Upon delivery, they can have difficulty establishing their respirators. Then they can go to Kipnik. You can have very coarse breath sounds because they're unable to clear it. You can start to see retractions as they slip into respiratory distress and cyanosis. So let's do some blood work. Basically, you're going to poke this baby. What is my blood work? Well, most frequently in these babies, I might get a CBC. I really don't care too much about it. I'm going to be looking at blood gases and a blood glucose. And when we're doing our blood gases, I'm not doing arterial blood gases. I'm doing a capillary heel stick. We're going to do a chest x-ray. This is hyper aeration. They're going to have a very distinct honeycomb look, and we're going to see bilateral infiltrates. What does infiltrate mean? you're looking at some sort of fluid in there. Usually when you see infiltrates in older children, it means pneumonia. So if this little one is struggling, we're going to give them oxygen, we're going to assist them with their ventilation, they might be placed on antibiotics, and they might have to have like a high frequency ventilator. We might have to give nitrous oxide to do vasal relaxation. Severe cases go on ECMO, which is a heart and lung bypass, and that would probably be a baby that is starting to circle the drain. ECMO, just FYI for your guys' put in the back of your brain, ECMO can only be conducted in a PICU, not a NICU. So ECMO, for example, would be at your children's hospitals. Your Lurie's would have ECMO, Rush has ECMO, UW has ECMO. I mean, we're talking big healthcare institutions. Your Swedish American Community Hospital does not have that. Your Mercy Health does not have ECMO, that sort of a thing. Apnea prematurity. When we're looking at central apnea, when we're looking at obstructive apnea, we're looking at true apnea being greater than 20 seconds. So I've had parents come in multiple times over the course of my career in pediatrics with babies who they believe have stopped breathing for short periods of time. And these babies do stop breathing for 6-10 seconds, and then they remember? Okay, that's not apnea. Apnea is going to be greater than that 20 seconds. These can also be compensated with changes. So you have a DSAT perhaps, and then they wake themselves back up and they move on with their lives. Central apnea, if we continue to have this occurring, we might treat that with phenylphylline or caffeine. Caffeine is probably more common. And then obstructive, if we're having obstructive apnea, this might be due to reflux. So basically these babies are feeding and then their parents or the nurses are putting them at like a 30 or a 15 degree angle and they're unable to tolerate that. And so these infants might need some special positioning, which might just mean like up at 30 degrees for 30 minutes or 30 to 45 degrees after they eat, and or some anti-reflux medications. We also might do some changes in their formula. Breast milk babies do really well with reflux because breast milk leaves the GI system so quickly, whereas in formula it can take a little bit more time to be absorbed, causing some issues.